Welcome to the Purr Podcast, your favorite feline-focused podcast, where we dive into all things feline, medicine, surgery, behavior, and of course, a sprinkle of veterinary gossip along the way.
I'm Dr. Jolle Kirpensteijn, feline fanatic, surgery nerd, and self-proclaimed lover of all things awkwardly cat-related.
And I'm Dr. Susan Little, proud cat vet, podcast enthusiast, and your guide to the wonderfully weird world of feline medicine. Let's get started.
Hello, this is Dr. Jolle Kirpensteijn.
And I'm Dr. Susan Little.
That was very fluent.
I thought so. I thought it was graceful, graceful.
Yeah.
You know?
Much better.
I had the right words.
Right.
Yeah.
Right. This probably goes into the top 5.
So the answer is I need to do the 3-2-1. It's when you do the 3-2-1. I think I've hit on the reason.
I think that the blaming game is not appropriate, in these kind of situations. So I feel that, that we started really well. It's slip sliding down.
So can you see why we are compared, apparently, so Jolle says, to the 2 grumpy old men in the Muppets. Mm-hmm. But before that, people compare us to a husband and wife who have lived together too long.
Absolutely.
Right?
Absolutely. You're in that 6th or 7th decade of living, and you don't finish each other's sentences, you cut them off.
I'm thinking about the coffin.
Okay, then.
Anyway, so we're talking with
Pamela Jones.
With Pam Jones. And Pamela, I think that we need to...
I'm glad you came back after the first part.
I think we need to talk a little bit about cats, because let's start with cats this time. And you're a medical and radiation oncologist. Name a couple of diseases in cats where radiation oncology is appropriate.
Well, first of all, injections like sarcomas. Mm-hmm. It's also been used in some of the oral squamous cell carcinomas, not to the success we would like, but I think there's still work to do.
Went through radiation.
And believe it or not, radiation is being used more and more in GI lymphoma.
I was going to ask you about that.
Yeah.
Because I've seen some papers and I've sat on grant review boards and I've seen,
Yeah, absolutely. It's, the thing, so definitely if you look at our human counterparts and what they do with radiation, for whole body radiation, for bone marrow ablation and such,
right,
it makes sense. But unfortunately in animals, we haven't perfected whole body because we haven't perfected bone marrow transplants. And especially in cats, it's just not something we think of. Right. However, what we have found is just radiating the abdomen in cats actually has shown improvement in feline lymphoma.
So it's not whole body, it's abdomen only.
Yes.
Okay. So I know clearly nothing about radiation oncology, but how do you not cause collateral damage when you're irradiating essentially a lot of organs?
It's a great question. It's a great question. And it's the line that we walk as radiation oncologists. And it's that whole respecting normal tissue tolerance for what dose we can give or what we can get away with without hurting damaging the tissues permanently. Because you can cause a little inflammation and the body heals itself, right? That's the beauty of like the feline intestine. It heals itself with that little bit of inflammation. You kill off the bad cells. Hopefully what you're exploiting is those bad cancer cells can't repair like your normal cells, right? Okay. So that's where you want to stay between.
So has it been used for sort of the uglier lymphomas, right? Because we got like good lymphomas and bad lymphomas. So are we thinking these like large cell type?
Yes. In fact, where I found success just dabbling in it when it was early on was the bad, nasty LGLs that cats would get. And it's like you're literally throwing up your hands going, well, this will be weeks. And I've hit a couple of those big, nasty ones. And it's like, wow, this cat's acting pretty normal now.
In conjunction with chemotherapy or as a standalone? Or?
Yeah, the tough thing is you kind of have to use it in conjunction with chemotherapy. I wish it were a standalone. And truly, I honestly, you always remember the cats that do really amazing or the ones that do really poor. But the cat that I remember the most is these owners had very little money. It's a huge abdominal intestinal mass. And I literally did manual planning, very quick doses to what I could feel of the mass, did manual planning, and I would give it a dose. And they would be like, we can't afford all 6 doses in the next few weeks. Can we just come back when she's sick again, or when we have the money? And I'm like, absolutely. We had that little cat limp along for nearly a year.
Go away.
With just doing a dose and saying intermittent. And I'm not saying that's the way to treat it, but for that case, for that patient and that client, that's what it was. That pet owner thrived on that.
I love that story because one of my soapboxes recently is we got to get away from thinking there's always a gold standard. There's always one way. Spectrum of care.
We have to offer spectrum of care.
And you know what? I think those of us, and I will include the 3 of us in this, who have been doing this a while, we all had to do spectrum of care, did we not? Yes. Especially early in our careers. I didn't know it was a thing. I didn't know.
Oh, yes. Right? It was, you always had to, I could say I saw 6 lymphomas today, and every single one of them was different. Or I saw 6 cats with an injection site sarcoma, and every one was different. Now, there's different tumor characteristics and everything else, but you have to look at your client. And the famous thing I always say to clients, I like, look, there's no right and wrong in this office. What is right is what's right for you and your pet.
I like that.
And that's the decision I have to help you with.
Right. I like that.
So do you normally talk about all the options you have, and then you say, okay, I prefer this one, but this one is pretty good too, and this one is the least option that I would do? Or how do you do that? Because it is, spectrum care is really important, but on the other hand, as a health provider, you also probably coach them in the best option that they have.
Absolutely. I think we obviously, I always say veterinarians are salespeople too. We just really believe in what we do. So we don't feel like we're salespeople, the quintessential salesperson. And truly, part of it is getting to know the client in that first 10, 15 minutes to know what are your goals? What do you want from this? What are your fears? What are, what's going to be best for you? Kind of just gauging. And then and I always tell people I could probably offer every client 20 options, but I kind of like to give them, okay, this is what we're looking at for the best. Right. And this is what that dollar and not even dollar amount. It's, you're going to have to come for the next 26 weeks. You're going to have to come for chemotherapy or the dedication of what you have to do. There's so many things that we do for pet owners, cat owners, and I just think later, I think, wow, if that were my cat, I wouldn't have the time to take them every day or every week.
Right.
We talked to Jessica Quimby yesterday about caregiver burden.
Yes.
Right?
It's huge.
Yeah, it's huge.
It's huge. And caregiver burden, I mean, I've dealt with it with my own family on the human side, but on the pet side, it's guilt of time, it's guilt of money. There's so many things involved with it. Yeah. And you have to realize that they have to take care of themselves too, you know, and it's amazing that we have to recognize that. We have to.
Yeah, we have to. And that's especially why I like your story about this cat with the intermittent radiation, because who would have, I think to your credit, there certainly would have been oncologists who wouldn't have offered or wouldn't have done that.
You're right.
Right? Because it's inappropriate, however you want to phrase it. But informed consent, you have no other options, right?
Yeah.
That's the art of the veterinarian.
In that regard, you have a little bit more freedom in private practice.
Yes, I think so.
The university situation.
I definitely think so. I think you have a little bit more freedom on helping the client make a decision that works for them, and versus trying to follow protocols and things that the hospital wants you to or whatever. But private practice, you can do that.
And it's probably the same thing in corporate practice, that they prefer you to follow protocol, prefer you to sell up things and that sort of things. Well, if you're independent private practice, you cannot decide what you want. I remember from university is that we also have a teaching part for the students, so we want to teach them what we call the gold standard, hopefully, so that they know that it's there. And then we realize that a lot of them probably will not do that in real life. And I always compare it with soft tissue surgery and orthopedics. So the orthopedic surgeons are really wary of giving away their skills.
Yes.
Because they're afraid that people will do it. And as soft tissue surgeons, you know that they're doing it. They do all the surgeries that you do.
So do you mean giving away their skills to a GP?
Yeah, so being afraid that they can do the same thing. And the thing is that I know that even in soft tissue, if you have a tumor, you better have it cut by someone that knows what he's doing or she's doing. instead, because those animals and those people that go to the specialist have a better survival rate than people that just
GPs can't be expert in everything. So.
They can't.
But they will still do these procedures, and you need to be accepting of that.
Give it a shot.
Right, and there might be owners that say, hey, I don't have the money to go to the university, and I want you to do it.
Yeah, but just as well, we don't want to see a GP tackle something without even giving the owner the option. The owner may well have said, sure, sign me up, I'm going, right?
And I think that's one thing that with oncology that I see a lot is they're like, oh, a GP can't do that. And I'm like, that's where we need to realize that a GP can do some of these things. Right. And I'd rather work with the GPs and educate them on how to do it right.
I'm so glad you said that, because I have been doing some chemotherapy in my practice because in the beginning, it was me or nobody in town.
Absolutely.
Right? Yeah, that makes him like... It makes him like go pale.
I can imagine.
Yeah. But I do.
I get sweaty.
He does. Yeah. He gets faint. So, but I think that's an excellent point, though. There are things GPs can do.
Right. Lots of things GPs can do. And nothing bothers me more than to think that there's these, care deserts is what they're calling them now, where an owner can't drive 3 hours to come see someone, but there's someone like you that should be able to. And I hope those GPs that are out there, I hope they're picking up the phone and saying, hey, I know I'm not you. I'm not going to go do a 3-year residency, but can you help me do this the correct way? Because that's really what we need to do. We need to work together.
Oh, agreed.
And just make that spectrum of care available.
That's another really good point. Every year we see so many more vet schools and specialty hospitals and clinics that you don't really think there's areas of the country that are a bit of a desert.
There are. You don't think of that. Care deserts out there.
Yeah, we don't think of that.
Even for just a general practice. There's huge care deserts where people cannot get care for their animal.
Wow.
So what were the most frustrating cat tumors for you?
Well, squamous cell carcinoma. Oral squame. That's the one. That's the one that literally, and it's just as frustrating in people when people get it, right? So it's the human equivalent is awful. And the other one was injection site sarcomas. And I think injection site sarcomas, even just yesterday, I was talking to an oncologist and she saw one last week. And I said, please tell me it was located on the limb. She said, no, I had to send it for radiation because it was right up on the pelvis. And I said, I just want veterinarians, you guys, we may not be able to prevent it from occurring, but we can prevent it from being catastrophic.
Right.
And that's a good way to look at it. Because, in the beginning when the message was on a limb, low as you can go, right? Because you can cut it off.
Yes.
There was a backlash against that. Like, how horrible is it to say to an owner, I'm, vaccinating around Fluffy's stifle because if Fluffy gets a tumor, we can whack his leg off, right? But
it sounds awful.
Whether you like it or not, it's the truth.
Yeah. And whether you like it or not, I can't tell you your cat is more of a risk than the black cat sitting out in my lobby or whatever. We don't know the exact etiology. So you look at it and you go, well, if I can't prevent it from happening, at least I can make it tolerable. And I think that's it. Or I said catastrophic because,
like that,
but what I think vets don't realize, that's the hardest thing about our cat friends. Cats can be very nice, but they've also got a fuse like Jolle here, that, man, you hit the wrong chord. And so I think inherently some vets are a lot intimidated by that. So you have the cat on the exam table, and does a cat just lay on your exam table like he's lounging in front of the sun? No, he's in a ball, right?
You got a scared cat.
Exactly.
You got a scared vet.
I know. And I tell vets all the time, I'm like, guys, when they're in their little hunched position, if you think you're vaccinating the leg, you're probably vaccinating the axilla or the flank or,
I've done it.
Yeah.
And so true.
And I'm like, guys, just take a minute, let the cat chill a little, get your technician to hold the leg for you, and make sure you're by the stifle.
That is so true.
And you can explain that to the owner in a nice way. You don't have to say we want to chop the leg, but explain to them, we've shown through science that this is the safest place.
So wasn't there a paper out of, I'm going to say Davis, but I could be wrong, that showed that these tumors, were, still intrascapular, but they were also finding them on the side of the abdomen.
And that's exactly, it's proof,
they're misfires.
Proof that they're misfires. You think you're hitting a thigh, but you're not. You're hitting a flank. And it's how cats position themselves.
In Europe, I don't know if it's still true, but in Europe for a while, they were preferring injection along the abdomen because they preferred to take it off there than a limb.
I do.
Yeah, you do?
Yeah.
You prefer taking a big abdominal wall.
It's easier. It's even easier than a leg.
Yeah.
So
and potentially even better.
But do they catch it early in those locations?
They do, because in Europe we're really checking hypersensitive for memory tumors. So we check every.
Oh, that's true. That's true.
Most of not only the cats, but most of the dogs get spayed in a later age, so we know that we have to check. So students are trained that every time you see an animal, you need to check the memory chain. And so, yes, they will. But I think the options were distal in the tail, which I hate.
Which I think is a bad idea in many ways.
Distal in the leg, or near the abdomen in a spot that you can remove. However, that means if the cat is in a ball, you will not be able to reach that.
Yeah. Very tough.
Yeah, there you go.
Very tough. Yeah.
Do you feel there's less injection site sarcomas these days?
Well,
what's your feeling?
I was thinking there was less, and actually, like I said, I was having a discussion with a colleague yesterday, and she said I probably see the same amount. She said it's not 25, 30 a year. She said it's probably one every other month, but that's the way it's been the last 10 years.
But kind of plateaued like that.
Yeah, it's plateaued there, I think.
Sarah Boston says the same.
Yeah. I bet she does. Yeah. And she's probably seeing some of the difficult ones too.
Yeah. Oh, sure. Yeah. But thankfully, it's not what it once was.
Yeah.
So what is the solution for squamous cell carcinoma?
Yeah.
Wow.
Well, what's your wish list? Like, if you, what approaches do you think? If you had all the money in the world, what would you try?
Oh, you know what? I would love, and this is where this is really pushing it. And how do you identify oral things in cats earlier?
Well,
and much like us, when we go in, I just had my annual cleaning. What did they do? They did the little light thing and did a cancer screen. And I wish we had something that literally we could get done very regularly in cats that was easy. Unfortunately, there's nothing at home that, and you the statistics.
My husband's a vet, and we did not detect it in our own cat until it was big.
Until they couldn't eat or they're drooling or something, and you're like, why? And
wonder if there could be like a saliva test.
That's right? What I'm thinking is something that will show it up sooner that you could do very easily, which they are looking at microbiomes now.
Right.
And cancer in the microbiomes of the oral cavity and cancer. Yeah. And maybe that's what it could come down to, is something like a swab, a quick swab. And ideally the perfect thing, because, we don't want to bring cats to the vet all the time. Owners have a hard time with that. And so how about a quick, easy swab they can do at home?
The issue with the squamous cell in the mouth in the cat is that even if it is small, it's still really, really tough.
You have no room to work.
Especially under the tongue. That's the worst location that you can have in a cat.
Yeah.
So you need to find it microscopically. So I'm looking more at, markers in the blood.
Yes. Yeah.
So you can say, hey, there's this peak now coming up. It's like what they do in people with prostate antigen. We could have find something that you can find something.
Pick up and say we have to look really close. We have to sedate your cat.
It's not only for diagnosis, but also for therapy, so that you can see that it goes down and not comes. It's not there anymore, because it's just it's a really tough tumor.
It is, and correct me if I'm wrong, but short of surgery, we haven't made any progress in 30, 40 years.
There's been
nothing really.
Not to speak of.
So the interlesional homing was quite successful, I think, but that's a human.
It's not accessible.
It's not
accessible.
Right.
Yeah, not accessible for our patients.
Yeah, not accessible.
And I think, that's tough.
So you're working in drug development?
Yes.
Okay. So for cancer drugs, or?
Yes, we have cancer drugs, but we also have wound healing, antibiotics, and anti-inflammatories in our pipeline.
Okay.
So
what are you excited about?
What you can talk.
What I can talk about. Boy, I am excited about, right now, I have to say I'm excited about some of the stuff that our drug is doing on the human side for oncology, for solid tumors. The drug I'm really excited about, and I don't know what its applicability is going to be in vet medicine because we do co-development, but it's a wound healing drug. And it is a wound healing drug that, so the problem in animals is, for the most part, animals heal. And that's to our advantage as vets. I remember a vet saying to me, that's going to get better in spite of what you do, 75% of the time.
True.
And I was like, so you're saying I'm just here to muck it up? And he goes, yeah, but their body will fix it anyway, type of thing. And it was a really interesting way of thinking about it. But face it, I mean, most things heal in our animals. And that includes cats. Cats heal very well. The horses are the ones that kind of have injuries and they don't heal real well. Right. But this wound healing drug, I've seen it work in both cats and the D word, on these wounds that were there for like 6 months.
Yeah.
And the topical application, they suddenly, within 30 days, they were like nearly closed. And within 2 months, they were closed. And so we see that, but the question always is, when you're in pharma, is that a marketable drug? And I think the way things may go is it's a human marketable drug, and it's going in that direction in development. But once it's approved, we could always use it for those bad cases.
Yeah, I mean, we do see, I've had, I can particularly think of several cases of strep canis in cats that can cause, it's like, flesh-eating disease, right, in people. Same types of bacteria will do that in cats. And I've had several that end up with these massive wounds because you're always, debriding and cutting back. So, like, right off the bat. And what about traumas and injuries and shearing?
And that's the key, is it's those kinds of things that we can maybe prevent from either getting bad or stop them when we do recognize them, stop them from going further. Because the specifics of ours is, it's got biofilm, it disrupts biofilms. And so there's a lot of good things about it. And so I think that's exciting to me. Wound healing, I'm an oncologist and I just love wound healing. I think it's just one of the most amazing things that, and I should say this quietly, that I think we do poorly in vet medicine because I think most vets don't understand wound healing.
Absolutely. And also, if you look at it, what tools do we have? What drugs do we have? Like, it's a desert.
It's a desert, and it's do this, wet to dry bandages. But I think what the problem is in vet medicine, I think we all need to go back to basics. And what phase is that wound in? Does it need debridement? Does it need? I mean, where are we at? And I think the problem is we try and cookbook it sometimes. At least what gets said to me and what I get questioned about. And I'm like, well, that's the wrong application for this phase of this wound. We need to, So I think wound healing is exciting. I think the frustrating thing with that, beyond products, I think the thing that we all wish would happen better is that regulatory models would improve faster. The FDA is doing a good job of getting non-animal models, as in ones that are more laboratory models and in vitro models versus, I think we were talking the other day about drug development in cat, and I was like, we don't want to go that direction because we'd have to sacrifice 40 cats to even do the tox study. And that's just, we have to have better models. We have to use comparative animal models that are live and provable on the tox side. And
it's finally being a bigger push, I think.
It is.
Aren't we? I think the industry is speaking up better. Researchers are speaking up like we really never did before.
Much better.
Yeah. And you had your question about organoids.
Organoids are phenomenal.
What is an organoid?
So just the way I think
I know this is out of the blue.
Yeah, no. It's I thought it was the coolest thing, because what it is we do most of our studies, on whatever it is, we do most of them on just a flat single layer of cells in a dish. And an organoid is literally, think of it as a ball of cells basically interacting with each other and in the way they should. And so it's much better for, modeling for cancer and modeling for drug resistance and
how do you make an organoid?
Well, there's people that make very good organoids. Yeah,
because they want to just form a layer.
Yep, you have to have a special culture media, and it's the first time I was like, "What is an organoid?" I was like you, and literally when you start seeing the pictures of these in some of these scientific lectures, it's like, So you created a little world, a little organ, a little organ of that.
And
stem cells in there. And,
it was in the context of stromal cells that this question came up.
Yeah, in Utrecht they've developed liver organoids. So that's just little livers.
Wow.
Little tiny livers you can test on. Yeah. And it's becoming the way for so many things to say, okay, we've screened that drug. Okay, you can skip that level and go to the next level and not have to do all those talks.
And it accelerates things too, which is because animal studies take forever.
It's brilliant.
Yeah.
It's brilliant. So I think my hope would be, and I think that the greatest thing that human pharma is doing now is they're recognizing the value of comparative modeling and comparative animal, and understanding that it not only benefits the animal, but it benefits them highly. It's a lot less expensive. It's an accelerated program. They have the same environments as we do.
Sure.
There's so many reasons to do it, but I think they're finally recognizing. In fact, a lot of the bigger companies in human pharma are starting their own in-house kind of programs in comparative oncology.
Are they really?
Yes.
Now that's something I wouldn't have thought.
And Sean Conner, he even said today, he said, I was a little offended by that, but now I'm like, right on, you go, because originally 20 years ago, he's like, can you really do this right? And now it's like, yeah, do it. Do it. The more we can do it, the better.
It's about time that we're not considered the poor stepchild of medicine, right?
Yeah. It's a great, I mean, really is a great thing. It's great for our patients. Sure. And that's one of the reasons why I served on advisory boards and such, as I realized, hey, if we do these clinical trials in the practice, that means I get to give more opportunities for my patients.
Right.
Absolutely.
And it's,
and it is tied together, right? If our patients do better, then their human family is impacted by that. You really can't tease them apart.
So. You can't.
Wise words.
They're very wise words.
I know.
Very wise words.
It's a wonderful podcast again.
You're ending the podcast again?
Yeah.
That human-animal bond and how important it is.
Okay. Well, and on a warm and fuzzy note.
Right. There is a bright future ahead.
There's a very bright future. I think we've come a long way. We've come a long way, and we're getting, and it's moving faster and faster. The door's open, and we're running through it.
That is indeed a good note to end on, some optimism.
This is the Purr Podcast, where we talk cats, laugh a lot, and learn something new every episode. Together, we bring you the latest updates, surprising cases, expert interviews, and just a touch of chaos, because nothing with cats ever goes as planned.
So whether you're a seasoned veterinary pro, a new grad, or you're just here for the cat puns, you've come to the right place.